Welcome to AETCM, the Emergency Medicine channel. Today we will be discussing a case of regular narrow complex tachycardia. Okay, so a 50-year-old female was brought to ER with complaints of palpitation for the last few hours. Initial 10-second assessment, the patient was conscious and oriented. Her vitals were a heart rate of 180 per minute, a BP of 120 over 80 millimeters of mercury, and a saturation of 98% in room air. And she was connected to the cardiac monitors. And since her heart rate was on the higher side, and we had asked to secure 2 large bore IV cannulas.
Large bore IV cannula secure.
Cardiac monitor connected.
So cardiac monitor was connected, and the cardiac monitor was showing a rhythm of narrow complex tachycardia, and it was regular. So since the patient is a stable case of regular narrow complex tachycardia, that is, there are no signs of hypotension, chest pain, like altered mentation or any features of shock, and there was no features of heart failure also. So we will have to initially go with the vagal maneuvers. We have to check for the carotid bruit, and if there is no bruit, we will have to give a carotid massage.
No carotid bruit.
Since there was no carotid bruit, carotid massage was given, and we will have to check for any change in the rhythm. There was no change in the rhythm, so we will have to give the pharmacological agents. So we can give injection adenosine 6 mg IV bolus followed by 20 ml NS flush, and we will have to elevate the limb.
Adenosine 6 mg followed by NS flush given and elevated the extent.
We will have to check for the response. So patient's rhythm is actually getting converted to a sinus rhythm, but it was a transient response, and the rhythm is getting again converted to a regular narrow complex tachycardia. Again we will have to check for the vitals or any features of instability. So patient's vitals were rechecked, and her BP was showing 80 by 50 millimeters of mercury. So we will have to go for synchronized DC cardioversion. So for a synchronized DC cardioversion, we will have to get the consent of the patient. We will have to get the crash cart arranged. We will have to adequately sedate the patient since it is a painful procedure, and we have to explain the procedure to the patient and perform it. So for a regular narrow complex tachycardia, we can start with a 50 joules and increase it according to the response. And Dr. Manna, you can proceed with the synchronized DC version.
So since it is a narrow complex tachycardia regular, I will be selecting 50 joules initially, and I will be pressing the sync button, and I will be applying the conductive jelly, and we have 2 paddles. One will be in the right side infraclavicular region, and other will be in the apex, and we will be charging, and we will be delivering the shock. So while we are delivering the shock, we will press on to the shock button, and then we will keep for at least 10 seconds so that the shock is delivered.
So after the shock is delivered, we will have to check if the rhythm is getting converted. So here the patient's rhythm is getting converted to a sinus rhythm. The heart rate is 120. Again the vitals are reassessed, and it is showing a BP of 120 by 80 millimeters of mercury. Patient has no altered mentation. Patient has no other features of instability, and the tachycardia, the regular narrow complex tachycardia got settled. That is the end of the management of a regular narrow complex tachycardia according to the ACLS guidelines.